transplant for multiple sclerosis, systemic lupus erythematosus, Crohn's disease, stiff person syndrome, and CIDP, and published the world's first randomized clinical trial for patients with systemic sclerosis and multiple sclerosis. Has been awarded Leukemia Scholar of America, the Lupus Foundation for America Fidelitas Award, the Van Beckum Award by the European Society of Blood and Marrow Transplantation, and it was presented the Keys to the Vatican in Vatican City in Rome. Was speaker for the Festival of Thinkers in Leadership in Healthcare in the United Arab Emirates, and chaired a biotechnology session in Baku, Azerbaijan, at the International Humanitarian Forum. Dr. Burt was recognized by Science Illustrated for accomplishing one of the top 10 medical breakthroughs for the next 10 years, and by Scientific American, one of the top 50 individuals, teams, and organizations for improving humanity and outstanding leadership. Again, please welcome Dr. Burt for our grounds today. Thank you. Go ahead. Please go ahead.
Yes. Thank you so much, Stefan. Can you hear me?
Yes.
Okay, so I'm going to talk, we only have less than an hour, so that's a lot of material about HSCT, or hematopoietic stem cell transplant, for multiple sclerosis and scleroderma. I use the word scleroderma because that's what patients say, but the real name is systemic sclerosis. Scleroderma means hard skin. There's other things that cause hard skin, but it's systemic sclerosis, scleroderma are often interchanged. Anyway, there's a lot of confusion in this field, I've found, as I developed it and pioneered it over the last 35 years. And so I took the time to get out 2 books. One came out last year, and it's an academic medical textbook. It's on the right here, Hematopoietic Stem Cell Transplantation for Cellular Therapies and Autoimmune Disease. It's 686 pages with 140 professors and associate professors from around the world, and it's designed for researchers and clinicians in the field. And I think if you're doing transplant for autoimmune disease or interested in doing it, you'll find this very helpful. And then the other is, I wanted to get a book out there that was easy to read and for lay people to understand this field, to help remove some confusion. And that's this book that just came out this year, Everyday Miracles. And as you can see at the bottom, I was very fortunate to get the Dalai Lama to do the foreword, His Holiness the 14th Dalai Lama. Now, this is not a religious book. It's actually a book that I was about the development of the field of transplant for autoimmune diseases. And it's kind of a history of different patients, 54 different patients, what the disease was doing to them, what their treatments were doing to them, how they weren't getting better, and then they had a transplant and what they were like afterwards. I was going to call it Profiles in Courage, but that's really what John Kennedy wrote as a book that I read as a child, so I didn't want to do that. And one of my nurses came to me and said, you know, call it Everyday Miracles, because one of your patients called me once and said, what's it like working with Dr. Burton? Before she could answer, patient said, I bet it's like seeing Everyday Miracles. And so do read it. As a physician, I'm guarantee you'll learn a lot. It's also fun to read. It takes me back to my years in college in the humanities. I think you'll really enjoy it, kind of like chicken soup for the soul type of book. And you'll learn a lot too. And everybody that's read it enjoys it. It's just getting people to read it. But anyway, because in an hour, I can't nearly cover this, what I spent 35 years working on, these 2 books will really help you, and they're very up to date. So I noticed when I had to sign conflict of interest, and there's no drug company involved in this for me, there never has been, but I had to say, according to your rules there, it's kind of the first time I've come across this. It might be a new thing for California, or maybe it's national, I don't know. But in any event, it had to say that this therapy is not FDA approved. I have to say that. It is not FDA approved. So I put that disclaimer up front. HSCT for multiple sclerosis, systemic sclerosis, or scleroderma is not FDA approved. And I'm sure the reason that's put there by somebody from above is because they don't want to mislead people. But in fact, is this factual statement a misdirection? And I think it is, because it kind of hangs a scarlet letter around people. If it's not FDA approved, there's something not quite right about it. And this, I put this up, The Scarlet Letter, a book written by Nathaniel Hawthorne back in, what was it, 1850, about a woman who got pregnant outside of marriage and scorned by the community in the public square for that. But she kept her silence, and she was actually the one with dignity and integrity. Although the system failed to recognize that. And this book brings that out in a wonderful way. I thought we were done with those in our society, but I think it's coming back out in social media, hanging scarlet letters around people. And I think this very statement, although well-meaning, hangs a scarlet letter around this. So I have to, at the end of this, come back to this and say, why isn't this FDA approved? It's our system. It's not that there's anything wrong with it. It's doing the right thing, and it will not be FDA approved. But in any event, I first will talk quickly about these two diseases. So I don't know what's going on. It's not going forward. The first I want to talk about is, systemic sclerosis. And what I put up here is a quote from one of my patients, that he said this disease is an anaconda that slowly squeezes life out of you. And I thought that was a very accurate description of it, and what it feels like for patients who suffer from it. There have now been 3 randomized transplant trials: ASSIST, my own, ASTIS, the European, and SCOT, the American, from another group, that shows superiority for HSCT over standard of care. Standard drug treatments have failed in randomized trials, every single one of them, yet they're used all the time to treat the disease by rheumatologists. I'm not talking about trials for pulmonary artery hypertension. I'm talking about trials for this disease as an immune-based therapy. In fact, I highlight here Cytoxan. Cytoxan was reported in New England Journal, daily oral Cytoxan for 1 year versus a placebo, as having improved the forced vital capacity. But in fact, improvement meant it still decreased. It worsened. It got worse. It just did not get as bad as taking a placebo or sugar pill for a year after taking it for 1 year. Well, you can't continue to take oral Cytoxan forever. It gives myelodysplasia, bladder cancer, all these things. So after 1 year, they stopped. Although that was reported in New England Journal, a year later, they reported the 2-year follow-up. And in the 2-year follow-up, there's absolutely no difference between taking a placebo or a sugar pill and taking Cytoxan for 1 year. Absolutely none. Not only, they both declined at exactly the same numbers, not just, there was no statistical difference, there was no difference in the numbers. And in this trial, the DLCO, even in the first New England Journal report, declined even more than in the placebo group. It just wasn't statistically significant. At 2-year follow-up, they both declined exactly the same, but that was reported in Annual Review of Respiratory Diseases, so most people don't read that. So Cytoxan became standard of care. It failed. So you can read all these trials that are standard of care out there, and they just don't benefit, unlike transplant, which showed reversal of lung function, improvement in skin score, and marked improvement compared to a control. In any event, the EBMT, European Bone Marrow Transplant Association, EULAR, which is the European League Against Rheumatism, CIBMTR, ASTCT, all recognize HSCT for scleroderma as standard of care now. As far as relapse remitting multiple sclerosis is, I think Ann Romney, the wife of former Republican presidential candidate Mitt Romney, said it takes away who you are. And that's a very good description. Perhaps another way of looking at it, as Rene Descartes said, the philosopher in 1595, who wrote, how do I know I exist? How do I know I exist? And he said, I think, therefore I am. That's the only answer to understand that I really exist. Well, MS destroys that ability to think and move and feel, and it takes away who you are. HSCT improves quality of life in relapsing remitting MS. Drugs do not. They absolutely do not. And I'll show you that data. HSCT reverses neurologic disability. Drugs do not. Well, if drugs, and there are about 17 FDA-approved drugs now for relapsing remitting multiple sclerosis, if they do not improve quality of life and they do not improve neurologic disability, why are they FDA-approved? They're FDA-approved because they decrease the number of relapses, or they decrease the number of lesions on MRI. They don't reverse them, they decrease them compared to doing nothing or the weakest drug out there. So a randomized HSCT trial showed superiority over the best drug therapy available. That's published. I did it. It was in JAMA. And now the EBMT, CIBMTR, ASTCT, all these committees recognize HSCT as standard of care. So the FDA has not approved transplant for systemic sclerosis or relapsing remitting multiple sclerosis. Why not? Well, the truth is they never will approve it. And so as Morpheus said in, you can have your choice to take the blue pill, go back to your world, or take the red pill. So if you want to take the red pill, stay with me. But again, first I'll talk about these diseases. And when it comes to transplant for autoimmune disease, it's important to understand that stem cells have no therapeutic effect. They just reconstitute your hematopoietic and immune system faster. So if you use a myeloablative regimen, like showed on the right here, you have to give those stem cells, those autologous stem cells back, or they're not going to reconstitute. They'll die of aplastic bone marrow and infections and bleeding and so forth. These autologous myeloablative regimens are what you use in cancer. Do not use them in autoimmune diseases. Now, there are some centers, predominantly America and Canada, that do that. Almost every other center around the world does not do that, a rare exception, one center in Europe, but most do not. They use non-myeloablative, and I've always argued that's what you want to do. The rationale is not to destroy the stem cell. In the vast majority of autoimmune diseases in adults and for children, it's not a stem cell defect per se. It's a dysregulation of the cells that arise from these stem cells, that is your lymphocytes. And you just want to reset that without destroying the stem cell compartment. The only reason you give stem cells back is you hasten recovery. Instead of waiting till day 12 or 14 or 15 to recover, you'll recover around day 9. So it's obviously makes it safer, and that's why you do it, but you don't have to do it. And here are standard non-myeloablative regimens, the ones I'll be talking about today that I use most often, cyclophosphamide ATG. I'll also talk about this one, fludarabine, Cytoxan, ATG, rituximab. The important point is you can make a non-myeloablative without mucositis, without destroying the bone marrow, as immune suppressive as a myeloablative regimen. You absolutely can. There's no need for the mucositis, the toxicity, and the risks of myeloablative regimens. There is no such thing as non-myeloablative autologous transplant in cancer. There isn't. But that's what you want to do. There is non-myeloablative allogeneic, but not autologous. But for autoimmune diseases, you want to do non-myeloablative autologous because it's safer. This is very important. So when neurologists talk about drugs for MS, there are 17 approved ones out there. They know the risks of toxicity, infection, and efficacy varies by the drug they give. But when people talk about transplant, they just say HSCT like it's all the same. It is absolutely not the same. The risks of toxicity and infection and even outcome is going to depend on the regimen you choose, and those regimens have to be individualized for each disease and the optimal group of patients selected for each disease to get the optimal benefit. So I want to talk about systemic sclerosis, hard skin, scleroderma. It is really an autoimmune vasculopathy. And this hard skin is quantitated here by the Rodman skin score. Anytime you do a study, you want to do that. Because you can follow it for improvement or worsening. It is, however, vasculopathy. If you look at the capillary nail bed, this is normal, and here's early scleroderma, active and late. You see destruction of the capillary nail bed. It is an autoimmune vasculopathy. But for some reason, most people don't look at the capillary nail bed. In the old days, they did it with a drop of oil and a microscope. Now you can do it right with your laptop and a little probe that you put over it, but people don't do it. But it's really a good thing to actually visualize in these patients. And this is there's so much I can talk about. We don't have the time. Again, go to the books. But this is the first randomized trial. I did it. It was reported in Lancet 2011. Remember, there are 3 now out there, one in Europe, another one in America, and mine. And here's mine in Lancet 2011. And we compared transplant using cyclophosphamide ATG at these doses. They're important doses. No manipulation of the stem cells, no CD34 selection, versus intravenous monthly cyclophosphamide. Now, I just said oral cyclophosphamide failed in these randomized trials. There was never a randomized trial for IV cyclophosphamide, but those are standard drugs, oral and IV cyclophosphamide for this disease used by rheumatologists, so that was our standard. We did allow a crossover because this is a disease, kills 5% of people every year. if they have a skin score over 14 or lung involvement. So we allowed crossover to HSCT if after 1 year of your standard therapy you worsened, not stabilized, but worsened. And we took patients' skin scores over 14. It's not hard to get scleroderma patients with a skin score over 14. The highest score can go to 52. But that's a cutoff for having significant morbidity or mortality and who've had lung, heart, or GI involvement. This is the regimen, cyclophosphamide 200, the ATG. It's dosed up like this because that decreases fever. Stem cells are infused, and GCSF we start day 4 in the afternoon or day 5 in the morning. And these were the results. So remember this randomized trial. You can see here the HSCT group, if we looked at the skin score, it improves after 1 year, the blue line. The transplant group, it got worse by 1 year. It was worse. And these people were able to flip over to transplant. That's the dash group, and then they got better. And if we look at FVC, forced vital capacity, you can see in the transplant group, it got better. No drug does that for scleroderma patients, that's standard out there. But in the people on IV cyclophosphamide every month, it got worse, which is exactly what the New England Journal article said as success, that it gets worse. Just didn't get as worse as placebo, but by 2 years, it was the same as placebo. But here you can see it did what the New England Journal article says it does. Lung function gets worse. With transplant, it got better. When we crossed them over, it improved after a year. If we look at DLCO, it actually improved with transplant. It stayed about the same on the control arm, but if you crossed over, it improved. Total lung capacity improved with transplant, worsened on IV cyclophosphamide, the control arm. When they crossed over, it got better. Interestingly, if we look at volume of diseased lung, and I'll show you a CT scan of that, in the transplant group, the volume of diseased lung decreased. In the group that got IV cyclophosphamide, it worsened, and yet this is standard, not just for skin, but for lung involvement. When we crossed them over, it improved. Now, this is a lung of a patient with scleroderma, and these little white areas are diseased lung. This is the diaphragm, but this is all diseased lung here. And you can actually set Hoyt-Fields units that will circle out every area of a certain whiteness, and then you have a computer program that can read the area of diseased lung, and it shows it here a little better, and it tells us that before transplant, the area volume of diseased lung is 944 mLs. 1 year after transplant, here's the same cut, but of course you go through all the cuts and you do the analysis, and the volume of diseased lung is only 402 mLs. It decreased from 944 to 402 after the transplant. That's never been seen with standard drug therapy out there. It's a marked improvement. And when we took everybody together, those that were initially on control and crossed over, and those that had transplant up front, see a marked improvement in skin score, a marked improvement in FVC for everybody. DLCO really didn't improve. The total lung volume improved. I mean, the total lung capacity improved, and the volume of diseased lung decreased. So if you notice, the volume of diseased lung decreases, but DLCO doesn't improve. Why is that? That was kind of a little frustrating to me at the time. And I'll show you why that is after we continued the trial, where we switched from randomized but continued as non-randomized. So here's where we did it now at 2 centers, continuing in America and at University of São Paulo in Brazil, and did 89 patients. And that's the largest number of patients that have been reported for transplant for scleroderma to this day. And when we looked at all 89, you can see the skin score improved, the forced vital capacity improved, total lung improved. DLCO kind of didn't. So why is that? And when we looked, what we saw is if you had a normal electrocardiogram going in, it improved. It was abnormal. I mean, flipped T waves, any abnormality, it did not improve. And that's because this is a vasculopathy and it involves the heart. It always involves the heart, almost always. And the heart contributes to the DLCO. It's not just the lung, it's the heart. And so, if you get it when you're not seeing really any obvious heart involvement. Now, to figure out how the heart is involved, you just don't need an EKG. You need a cardiac MRI, you need a cardiac cath. This is a vasculopathy. The #1 cause of death for patients with systemic sclerosis is heart. And some papers say that, others say it's lung, but they do not suffocate. They don't drown, they don't suffocate. Their heart gives out. Now, it may give out from pulmonary arterial hypertension due to lung disease, but it's ultimately the heart, and the heart is almost always involved in these patients. And that's very important to recognize if you're going to transplant these patients. So when we look then at all of our patients, their overall survival versus relapse-free survival, well, so we had about 25% relapse, the rest never did. But when we looked at treatment-related mortality, which was 6% in our study, remember the natural history of these patients, 5% per year die. So they, after they got through the treatment, then they did much better. But we had 6% mortality. That was not satisfactory for me. I wanted to make that less. And the cause of that mortality is heart failure. And it's as simple as giving normal saline. This very innocuous bag of salt water that you give people all the time, you don't worry about, can, in a patient with scleroderma, precipitate heart and lung failure, and they can die. And the other thing happens to scleroderma patients, it's very common for them to come in with a low blood pressure, a fast heart rate. They have peripheral shunting, and they have a very stiff ventricle, because this is vasculopathy. The ventricle is stiff, like an amyloid heart. And if you've ever done a autologous transplant for amyloidosis, it's a stiff heart, just like that. They cannot tolerate fluids. And people look at the stiff skin, but they don't realize that the heart is stiff. So you definitely do not want to hyperhydrate these people like you do in most transplants. I have seen them die from that. And I know of centers that's happened. I saw it actually in a center where I was treating, where a patient came in, and at night the hospital put them on fluids because they were tachycardic with low blood pressure, but that's their normal baseline. That's normal for them. And they ended up, the patient dying. The other is this drug, phenylephrine. They got a low blood pressure, they're tachycardic, get in trouble, they go to the unit, they're going to push them on, they're going to put them on phenylephrine, and never do that. This causes further vasoconstriction, and these people already are maximally clamped and shunting in the periphery, and they have a Raynaud's in the heart with clamping of the capillaries. You saw what the capillaries look like in the nail beds there, and you clamp them further, and you don't get out of this. So I don't have time to go into how you really want to treat them, but you've got to fight with the ICU, because their standard practice is to give fluids and to put them on these very strong vasopressors, which you absolutely do not want. I worked with a very good cardiologist. We could tag team on them, get them to do the right thing. The right thing is not neosynephrine or Levophed. If you need a pressor, you use low dose dobutamine, that's helpful, or if you need to, you can add dopamine, but you actually want to use a low dose nitrite to open up that peripheral vasoconstriction in many of these patients, which is counterintuitive. It just doesn't seem at all obvious. Seems like it's the wrong thing to do when you have a patient with low blood pressure, but it can really save these patients. Now, the question then that I realized is, can HSCT for scleroderma be made cardiac safe? It's very successful, but it's a difficult transplant. And if you get into problems with the heart, this is a complicated process to get through. I know how to do it because I was at the bedside of every patient, but your ICU people will not know how to care for them. So because transplant for scleroderma is rare, transplant's rare, they just don't see it. So they go back to what's standard of care for them for a heart attack or low blood pressure. In any event, what you want is good patient selection. You got to screen out high-risk hearts. You need a cardiac MRI, or papers or publications. These books I talk about tell you how to screen them out. You need that MRI. You also need a cardiac catheterization with fluid challenge. And the reason for that, these are elective caths. So they're NPO after midnight. They may not get the cath till 2, 3 in the afternoon. They're intravascularly dry, and so if you don't give a fluid challenge, their pressures may look okay. If you give that fluid challenge, a liter of normal saline in 10 minutes, if you do that to a normal person, those cardiac cath values do not change. In a patient with scleroderma, they can go sky high from left heart failure or pulmonary arterial hypertension, and you know not to treat them, what values to look for in my publications. So we started screening out high-risk patients, and we stopped seeing cardiac deaths. Except some of these transplants still be hard, despite cardiac MRI, cardiac catheterization with fluid challenge and echo. You cannot 100% screen out these hearts. It is an autoimmune vasculopathy. The most important component in the vascular system is the heart. It is involved. So, but we screened out patients high risk, and they were frustrated because they're dying, and they would take that risk, and they're angry, but we wouldn't do them. And so you'd have to deal with frustrated patients. The other way to handle this is develop a new conditioning regimen, basically decreasing the dose of Cytoxan, which we did. And that new regimen is fludarabine at 30 for 4 days, a total of 120, and decreased the cyclophosphamide from 200 to 60, added rituximab, kept ATG the same. The reason we added the rituximab is in my publications. Time doesn't permit here, but this regimen has worked extremely well. It took one of the hardest autoimmune patients to transplant to the easiest. Initially, we only did high-risk cardiac patients, but they flew through so well with no difficulties. It's now our standard care regimen. We call it CAST, Cardiac Safe Transplant Regimen. And it is now the regimen. I've shared this regimen with Paris, France, and they're doing it there, Haifa, Israel. I was actually just gave a talk there. They had a day-long conference. They're using my study with very good results. So we just had a meeting there, Oslo, Norway, Canada. And it's at Scripps. It actually just opened today. They're at Scripps with final IRB approval. It's also, we'll be starting soon, Ribeirão Preto. And again, here's the regimen. And importantly, not only is it cardiac safe, but it decreased the duration of neutropenia from 10 to 5 days. Anytime you limit neutropenia and make it much shorter, it just makes these transplants a lot easier, a lot safer, a lot less expensive, and there's a lot less use of blood products, less red blood cell transfusions, less platelet transfusions, less risk of infection. It's turned out to be a great regimen for this particular disease. Now, what about MS? As Anne Romney said, it's a disease which you're losing who you are. And as Rene Descartes said, I think, therefore I am. And you start losing that ability to think, to have control of your bladder or bowels, to walk, to ambulate, to feel, it destroys who you are. And here's an MRI, these demyelinating plaques. These are typical Dawson fingers here in a sagittal section for a patient with MS. Well, there's a long history developing this, first with animal models, which I'm not going to go into. I don't even show my publications in the animal models, but there are animal models for MS like EAE that I worked in for 10 years, first starting patients as preclinical proof of principle. And then we reported in blood. We used a myeloablative regimen. We started with secondary progressive. That's the end phase of MS. 90% are relapsing remitting at onset. You give them enough time, and the majority will, over their lifetime, become secondary progressive, which is a neurodegenerative disorder. It's no longer immune mediated. It doesn't work. And I put in the title, failure. So I want people to understand that. Don't do secondary progressive MS. Now, you may not know what secondary progressive MS is, and that's one of the problems with this field, is the technology to do this is in the hands of hematologists that do transplant. But understanding this disease is in the hand of neurologists. And that's a real problem for making this field advance and go forward. So you just like there are people in oncology that specialize in just Hodgkin's or lymphomas, or whatever. You really need someone on your team that's going to specialize in MS, because you got to learn that disease. You do, because a neurologist will give them their drugs until they're secondary progressive, nothing works, and send them to you. And then if you don't know the disease and you don't know how to identify secondary progressive, what it is, you do it, and they don't get better. They may, in fact, even get worse. And some of the original, many for a long time in the literature, were showing results of secondary progressive MS or combining secondary progressive with relapsing remitting, especially coming out of registries. And it was nonsense data, because this doesn't work. It's a different disease than relapsing remitting MS. So my first study I reported in Lancet using cyclophosphamide alemtuzumab. Long story short, worked great, but alemtuzumab gives ITP. It does as a solo agent. It did in this regimen for transplant. We got rid of it. Why it does is also, I've published why that is. It's basically a marked, when you use that drug, you get a rapid increase in naive B cells with a very slow, beyond 1 year return of regulatory T cells. And that's how these ITP arises. In any event, then we switched Cy-ATG, reported 150 patients in Lancet. That was really good data. So that became the foundation for a randomized trial, this Cy-ATG. Now, Cytoxan at 200 here has no cardiac toxicity. These hearts are normal. The study was stunningly good, never seen before. Reversal of neurologic disability, improvement of quality of life, not seen with any of the drugs. The drugs are called DMT, disease-modifying therapies. And then we looked at the cost analysis of this, the health economics of transplant versus drugs. And then finally, recently, we reported all 507 patients, everybody on and off study, just so everybody's out there that went through a transplant, so that you're aware, because there can be patients done off study where the results could be different, or there may be mortality that's not on study, and we wanted everything out there. Now, just to show you, I don't have time to go through all this. I'll quickly talk about these last 3 articles. Here's the randomized trial. So you got randomized to transplant or continued DMT. You'd already been failing DMTs to get into this, but you then were switched to a different class, more aggressive DMT. And you can see in transplant versus DMT, neurologic disability basically the same, but continuing DMTs or drug therapy, they got worse. Whereas in transplant, neurologic disability got better. So if the disability goes down on the EDSS, it's better. It's marked improvement. They got better. With continued DMTs, even though they switched to a more aggressive DMT, they got worse over 1 year. We did allow, after 1 year of getting worse, that they could switch getting worse by the sustained worsening of their neurologic disability for at least 6 months. After at least 1 year in the control arm, they could switch over to transplant. And this, in that article, shows time to disease progression for transplant versus disease-modifying therapy, and the time to first relapse for transplant versus disease-modifying therapy. Now, these were very aggressive relapse and remitting, so they had to have had at least 2 attacks in the last year despite a prior disease-modifying therapy. And those attacks had to be confirmed and documented by a neurologist, hopefully with an MRI, not just some, pseudo attack. So these were very aggressive cases, and they markedly improved with the transplant. These p-values are, the journal made us cut it at less than 0.001. They're actually less than they're times 10 to the negative 10th. These are highly significant values. And then when we looked and published everybody, on and off study, 507 patients, although we wouldn't treat late secondary progressive, some people were, if you have a diagnosis of secondary progressive, we won't see you. They come from all over the world, all over the country, so we wouldn't even see you. We didn't want you to waste your money. But some people would come and they said they're relapse remitting. Their neurologist says they're relapse remitting, but when you see them, they're really secondary progressive. If they were within 1 year, we felt diagnosed secondary progressive. And when that occurs, it's a very gradual transition, so it's really hard to nail exactly when it does. So there's some ambiguity when we selected, we would treat them. So kind of these early secondary progressives, but never late. And they didn't improve in their EDSS. Yeah, you can say maybe they improved a little. But when we looked at relapse and remitting, there was a marked improvement in neurologic score. When we further divided these secondary progressives into having a gadolinium enhancement within the last year on their MRI, which means that there's active inflammation, they improved about 0.5 point. If they didn't have it, non-active secondary progressive, they didn't. So you can divide these into active secondary progressive and non-active secondary progressive. Do not treat non-active secondary progressive. You can still get improvement in active secondary progressive. It's just not as incredible as what you see with relapse and remitting. Now, if we look at all relapse and remitting cases, which were most of them over 400, you can see that, no matter how bad the neurologic disability at the time of transplant, so 10 is dead, 7, your bilateral crutches, canes, or maybe wheelchair, you can see marked improvement in neurologic disability independent of the score. The key is getting relapse and remitting. Now, I think the younger you are, the better you do. It wasn't in our data, but it is out of the European BMT registry, and that kind of makes sense also. Now, the summary for our 507 patients with MS undergoing transplant is a mortality of 0.4%. It's low, but it's not zero. It was not protocol related. You can say it was, but it wasn't. One patient died of Legionella from the water supply in the hospital. It was in the shower head, it was in the sink, it was in other rooms, it was on other floors in the hospital. So that was completely unexpected. One had sickle cell crisis and died before mobilization. So you have to be really careful, though, to select people and rule out any other illnesses they may have that could impact. But this was before mobilization, but because we'd already selected him for it, I included it as, intention to treat analysis. And so you have to warn people, expect 0.4% or don't do it. You'll find the vast majority of people want this. They'll be angry if they don't get it. HSCT has significant benefits in neurologic disability and quality of life for relapsing remitting MS. For active secondary progressive, that is, they've entered secondary progressive, but they still have enhancement in the MRI within the last year. Enhancement means active inflammation. They have modest benefits. If they're not active, it's not going to help them. Do not do it. This is a purely neurodegenerative disorder now, and you really need a true neuroregenerative therapy for these patients, not HSCT, which is an immune regenerative therapy. Now, I want to show you transplant versus the best drugs out there. The best drugs are Tysabri, also called natalizumab, Lemtrada, or Campath, alemtuzumab. And this is the studies CARE1, CARE2. This is Tysabri top study, which is a summary of all the studies with Tysabri, looking at improvement in EDSS. Improvement, the higher number showing the amount of improvement that occurred. And you can see with these drugs, even the most aggressive drugs out there, the improvement was less than 0.2. And they've often only shown them out to 2 years. Whereas with transplant, we have an improvements of 1.6 going out to 5 years. And that's improvement because the scale is it goes by 0.5. And for any one patient to notice improvement in their EDSS, they either need a 0.5, a 1, or a 1.5 improvement, depending where they are in the scale. And so these 0.2s mean it doesn't matter where they are in the scale. When you treat them, they didn't get any meaningful improvement out of it as a mean for the study, whereas you can see the difference when you go through transplant. The other drugs don't even report EDSS because it doesn't improve at all. Here, it's not clinically significant, but it's in the right trend. Here, it's markedly clinically significant when you do a transplant. When we looked at NADA, NADA means you're having no clinical relapses, no progression. That is, no worsening of neurologic disability, whether you're having a relapse or not, and no MRI activity. What we see is our NADA for our trial is, 80 to 90% going out to 5 years. For the drugs, and I list all the drugs here, they often only report out 2 years NADA, if they report it at all. And you can see the NADA is roughly half to a third. And these, are just here, alemtuzumab, cladribine, ocrelizumab, natalizumab, or Tysabri. These are very potent drugs. And you can see it's really a half in the most potent drugs compared to transplant in terms of NADA, no evidence of disease activity. The CLIMB study was a study out of Harvard where they could treat with any drug, and they followed them, out over time to see what would happen using the best available drug. And you can see by 5 years, they're down to 15% NADA, whereas we're at 80% with HSCT. Now, the reason people use NADA is there's no definition for a cure for any of these autoimmune diseases, including MS, so we can't say they're cured. But at some point, when you have no evidence of disease activity for many, many years, you're going to have to start realizing not only have you changed the natural history of disease, you may have to get a committee start thinking about how you define cure. And in fact, in my book, Everyday Miracles, which I show right here again at the beginning, these are patients now 10, 15, 20 years, as long as 21 years after transplant with MS, no evidence of disease activity, never started a new drug for MS, got better, stayed better. And so I need now to take the time, I don't know where I'm going to get it, but take the time to bring these patients back for a final analysis of wherever they are, 10, 15, 20, beyond 20 years, to report their status. But just, I was shocked because we stopped following them after 5 years. And I started calling these patients I hadn't talked to for 10, 15, 20 years. They're still in remission, still doing great on no drugs, got better, stayed better. I was so pleasantly surprised by that. You don't see that with drugs. You don't see improvement in neurologic disability. You don't see improvement in quality of life. And you certainly don't see getting off drugs and staying off drugs. You stay on drugs. Now, some of them, like alemtuzumab, you give 2 or 4 treatments, whatever, ocrelizumab every 6 months, whatever. But, these aren't designed to be one-time treatments when you're dealing with the drugs. If we look at quality of life, the SF-36, drugs do not improve quality of life. You're on them, you stay on them. They're FDA approved. They don't improve your quality of life. And in the reports, most drugs don't report quality of life. These drug trials are reported in New England Journal, in JAMA, and in Lancet. They do not report quality of life, because if they did, it would look bad. So in other studies, in lesser journals, so some report it, others don't. Tysabri, very potent drug, quality of life does not improve. Now, the SF-36 did improve by 1 to 2 points. What does that mean? That's a numerical improvement. And in their paper, they said it improved, and numerically it did, but it's clinically meaningless because the minimal change in SF-36 for a patient to feel an improvement in quality of life is 5. It has to improve by 5, and that's well documented. This is such a well-validated quality of life FS36 scale for all types of diseases that we know it must improve by 5. So it's not clinically significant. If you look at transplant, wow, we're getting 15, 20, 25 point improvement. It is clinically meaningful. If you go to Ocrevus, again, clinically irrelevant. If you go to Lemtrada or alemtuzumab, you can see an improvement of 3 points, but that's clinically irrelevant for a given patient. Of course, these are the means for the study, but here's the means after transplant. So drugs do not improve quality of life. It's why the endpoints of drug trials are not improvement in neurologic disability and not improvement of quality of life, because if they were, they wouldn't be approved. Now, I'm not criticizing drugs. They give you something that can slow progression of the disease, and the more you have, to different people respond differently, and once they fail, you can add a different one. Different people have different toxicities, so it's valuable to have them, but that's not what they achieve. Transplant does that. Okay, now, if we look at the cost of drugs, the cost of a non-myeloablative transplant is $100,000. That's what it is, whether it's an insurance company or patient. That's a lot of money, but the cost of a drug, that's a one-time treatment. And again, only about 24% relapse, and large numbers, once you're beyond 10 years, just do not relapse at all. So this is a transplant, which is a one-time treatment, although it sounds expensive as a one-time treatment, is highly cost-effective. If you look at the drugs and look at their current 2020 price, I don't have the most recent 2023, but you can see they're $100,000 a year, all of them. But you keep treating them every year. And if you look at the drugs, what happened when they first came out in market, interferon, 1993, it was 19,000. Another type of interferon, 13,000. Vladimir acetate, Copaxone, 12,000. But look, their prices in 2020. They markedly exceed the rate of inflation. They're up around 100,000. What they do, these earlier drugs, as new drugs come out and are priced higher when they first come out, the new drugs match their price. They absolutely match them. So you're paying an excessive amount of money. Transplant is cost effective. We've published that. Now, these are FDA approved drugs, okay? Transplant is not FDA approved. It never will be FDA approved, and I'll show you why. But anyway, the cost of Vladimir acetate, which is Copaxone, once the patent expired, its price dropped 60% in 1 year. Now that new price, and the second year, I'm sure it'll drop lower, but that new price is probably what profit there is in the current cost and production once you remove a patent. Okay. So FDA approval, going back to where we started, where what I'm saying now that we, from somewhere with good intentions, someone on the top you have to say at the beginning, as a disclaimer, it's not FDA approved. Well, that makes people think it's not effective. It's exactly the opposite. So what is FDA approval? That's what people are missing. First of all, to get FDA approval, you have to do an FDA drug trial, and the cost of an average FDA trial is $48 million, $50 million to do a trial, okay? So FDA trial is done to get an exclusive license. That's what it means. The FDA gives you an exclusive license to recover cost and return profit to investors who put into this drug company, whether it's shareholders in the company or entrepreneurs for new companies. So this is not a criticism against any drug company. It isn't. It's a reality. Drug companies have to shell out a lot of money to do this. So a drug company is not going to do it because the FDA is designed for approval for new drugs. So a drug company will never do it unless they start with one thing. What is the very first thing you need that a drug company needs before they will consider doing an FDA trial? Does anybody want to type that in if you can, or say? Okay, well, I'll tell you what it is. It's a patent. A patent means someone else can't take it also. A patent doesn't mean you can give it to people. The FDA trial licenses you to do that, but you have to have a patent on that drug or someone else will take it and do another trial. So the first thing you have to have is a patent. Well, lo and behold, hematopoietic stem cell transplant, that is, a hematopoietic stem cell is not a drug and it cannot be patented, especially how we give it, which is minimally manipulated. That is, it's a homologous application. It's a blood transfusion. It's doing what it's supposed to do, rapidly increase hematopoiesis. You cannot patent hematopoietic stem cells. You cannot patent hematopoietic stem cell transplant for autoimmune disease. Why can't you patent a hematopoietic stem cell? Well, if you could, if I could take your hematopoietic stem cell and patent it, I could patent your finger, I could patent your arm, I could patent your leg. And we've gone through that in history. That is called slavery. You cannot own someone else. You did not make them. And in fact, the Supreme Court got it right when the University of Wisconsin, when they came up with first to identify a human embryonic stem cell, they patented it. But that patent was challenged in court and it went all the way to the Supreme Court, and the Supreme Court said, you did not make that embryonic stem cell. You can't have a patent. So they didn't get a patent. What you could have done, the way you isolated that embryonic stem cell out of the blastocyst, the pre-implantation embryo, you could have patented that methodology, but there's no sense doing that because someone else would isolate it a different way. So the Supreme Court said it can't be patented, and they're right. And the reason they said it is, no, you guys didn't make that embryonic stem cell. You did not do that. That's like walking out and say, I'm going to patent gold. Gold is mine and everybody has to pay me whenever they see it. You didn't make it. Okay, so you can't have a patent. If you can't have a patent, no drug company is going to touch it. Why would they invest all that money? And at the end of the day, somebody else can make it. Okay, what about the conditioning regimen? The conditioning regimens are generic, meaning they're patent expired. Patents on drugs after 10 years go away. You can renew sometimes, but then they still go away. Thank goodness they do, because the prices drop. The patent is designed for the drug company for a period of time to recover their costs in running that trial for a new drug. But many, many drugs that we use are patent expired. Every drug I just showed you that we use to treat is patent expired. So if we're using drugs that are patent expired, and that, by the way, makes them cheap, but if they're compared to patented drugs, but if they're patent expired, no drug company will touch it because they'll do a trial and at the end of the day, someone else can run with it. So there's no profit in doing it. The FDA is designed for a drug company to have a patent and to get a profit on a clinical indication for a drug. That's what they're designed to do. They do not regulate. They have no oversight over non-patented drugs. So what happens? It's meant well. It's a system that works, but what happens is a pharmaceutical company will spend $50 million, but they're not at minimum. Sometimes they spend 100, 150 million on one drug to get the license, and that, if it works, if it doesn't work, so they lose the money. But then they have a monopoly, they can set the price, but they're not going to do it if they don't have a patent, and they can't in how we're doing this. And in fact, it gets abused. For instance, one of the newer drugs for MS, ocrelizumab, it's $40,000 US every infusion. They give an infusion, 2 weeks later, they give another one, 80,000. It's an outpatient, couple-hour infusion, 80,000 bucks. Every 4 to 6 months, they give another infusion, depending on the B cell count, and that goes on indefinitely until they relapse or toxicity or they progress or whatever, at 40,000 bucks. Well, the reason that was developed is because neurologists took rituximab, which is now patent expired, and they used it off-label in MS and found out it helped MS patients. So they started using it. So someone saw that, so they went and designed another anti-CD20. Rituximab is anti-CD20, anti-B cell. They designed another anti-B cell, anti-CD20 antibody called Ocrevus. They put a patent on it because nobody could have a patent on rituximab anymore. They did the trial, it worked, and they got a license. So all neurologists stopped using much cheaper rituximab, and they switched to Ocrevus because by doing that, they make more money. I don't think they're conscious of that. The institution is, but they're protected legally because of what I was asked to do here. It's FDA approved. Well, if there's no drug company, when Ocrevus was approved, they compared it to interferon, the weakest drug out there. There is no drug company that will compare their new drug to the most effective drug out there because it won't be approved. And that is all missed in medicine. If you were to compare Ocrevus to rituximab, they'd probably be equal efficacy. They're both anti-CD20. It was rituximab's effectiveness that made someone think creatively to use a new anti-B cell antibody to get a patent, but now the prices go sky high. They would probably be equally effective, but one would be much cheaper. No study will be done in America for that because no drug company will do it. Nobody has a patent for rituximab. They're not going to do it. And the drug company that has a patent for Ocrevus would think that's crazy. They could lose their market. And neurologists aren't going to do it. There's no money in doing it. That's the downside of what's happened with our system. So HSCT for MS and Scleroderma was undertaken as an academic endeavor to help humanity without profit, license, or monopoly or financial award. Yet, despite doing that, which is like above and beyond what our system is doing, you almost get a scarlet letter because it's not FDA approved. Well, it'll never be FDA approved, but it's much more effective and is highly cost effective. Again, the key is in the regimen and patient selection, and there is risk. There is risk with every single surgery and every single drug. I've seen in rheumatology where they infused rituximab, the patient, and as now patient had anaphylaxis and passed away. There is always risk in everything we do, and that has to be explained to patients. But in our society, it is consent that makes the difference. It's the patient living in those shoes. As long as they're adequately informed as best as possible, it is their decision. So I want to show you that what this is. Medicine is a profession. Healthcare is a business. And that's where conflict arises, okay? After a phase 3 study that is a randomized trial, you're done. We're done. Drug company makes money. But in fact, we should have a phase 4 study of cost-effective analysis comparing the newly approved drug against all drugs out in the marketplace for that condition, including the best drug available and including patent expired drugs, which are a lot cheaper, but it's never done. It never will be done. There's no financial incentive to do it, but the patients suffer, our society suffers. Physicians and patients need to be educated on cost-effective treatment because if patients or society are not financially secure, they have no medical or psychological security. It is true. But we don't know. As doctors, more and more I've seen in my career, when I was first left med school, we were the triple threat, you know. It was clinical, education, and research, and that's kind of vanished. Doctors are becoming employee of institutions, whether it's a university or a hospital, to generate money to feed the bureaucracy above them, because they're not generating the money. Well, the most expensive drug is going to generate the best money. It has the most profit margins on it. So there's no interest in doing that, but it's not helping the patient or society in front of you. It's our system that's gone wrong. So successful applications of medically effective and cost-effective but patent expired drugs are being unintentionally discouraged, just as I was told to give this talk, I had to put the caveat up front, this is not FDA approved, which implies something's wrong with it. It's absolutely not the case. Our current medical system is financially toxic. And I want to show you a result of our current medical system. These are FDA directors when they were directors. After they left the FDA, 10 of the last 11 FDA directors all became members of pharmaceutical companies. I mean, like presidents, members of boards, big involvement. The last one, Stephen Hahn, was a friend of mine. We trained together at NIH. He became FDA director. He, for just 1.5 years, left and took over, you know, in a pharmaceutical company. So that's not, these are distinguished people. It's not saying it's bad, it's totally legal. The reason it is pharmaceutical companies, it costs them a lot of money dealing with FDA rules, which drives the cost of drugs up a lot. They hire people from the FDA because they're the only ones that have the expertise and do it. And if they can get a director, they put them in the board and give them a lot of stock. Otherwise, there are a lot of people leave the FDA, they spend 20 years there, and then they go to a drug company and make a lot of money because the drug company needs those people. Otherwise, they get a scarlet letter hung around their neck because the rules are exceedingly complicated. If you don't believe me, open these FDA regulations, start reading them. So we, even as clinicians, don't know them. but they're not designed for bedside care. The FDA does not regulate bedside care. They are designed for the development of a new drug. In fact, when you use a patent expired drug, there's a long history of toxicities for those drugs. So as long as you're using a dose that's reported in the literature and you're not using it to get a license, it's FDA expired, of course you're not doing that, you have the right as a doctor to use it. If you didn't, people would be dying left and right out there. These drugs I talk about, steroids, Cytoxan, are used in almost every single autoimmune disease. You use them in like steroids, GVHD all the time. They're not FDA approved for that. They never will be. There's no profit in it. A lot of the drugs you give are not FDA approved, or they're not FDA approved for the indication, but you report it, it's in the literature, and it's in the benefit of those patients in that society. It's not in the benefit of the drug company to look at it because they don't have a patent anymore, or why do it in a new disease where physicians have already figured out and are doing it. So it just doesn't happen. All right, so I want to take you back. There's a lot of material I couldn't get into that are in these two books, and I really hope they're both on Amazon. You can just go on Amazon, pull them up. Again, the one on the right is a medical textbook, 686 pages. And the one on the left is a lay book, but as a physician, I guarantee you'll enjoy it. It is probably one of the most fun things I ever did in my career, writing this lay book. And I just want to say, you know, I'm getting older, so my time left in this world is California, IPS, and kill switch. What do those three things mean? I've been asked to write another book. I already have the title for it, Kill Switch. It is on a back burner just because I got so much to do. I want to see autoimmune disease go forward in the right direction, so I spend time at Scripps doing that. But most importantly, I'm not critical of drug companies. They have an important role. I am not critical of them. I'm just saying you have to understand our system, and you can't be critical of doctors. They're very important. They are the key to represent the patient, to get the patient through this complex minefield that is medicine, and to do it in the most cost-effective way. Doctors have no idea what the cost-effectiveness is. It's like taking your car into a dealer and you say you want the spark plug changes, and he puts in these $1,000 spark plugs made in Italy by Lamborghini. And you say, why didn't you put in something made by Ford? It's a Ford car. He says, tough, you're paying it. So doctors need to know the cost and the cost effective, not to get the cheapest drug, but the most cost effective. It's better for the patient, it's better for society, because we as a society can no longer continue in this financial toxicity that's occurred and developed because of our system. Well, anyway, I want to see autoimmune disease go forward the right way, but I have 7 patents with IPS. We've developed a biotech company. We want to bring that to clinical trials. So yes, I'm on the drug development side of this too. I am not critical of the extensive costs of regulations and of development that drug companies have to go through. I'm just saying, when you apply it in the wrong place, it's negative for the development of good medical care for patients. Thank you.
All right, great. Thank you so much, Dr. Burt. We have a couple of questions.
Great.
So first from Dr. Shavan, who is he's leading the transplant program at CHOC, Children's Hospital here in Orange County. He is asking, what about the role of selective T regulatory cells in transplantation for MS or other autoimmune diseases?
Oh, excellent. Excellent. We talk about Tregs in the medical textbook. Get it? There's a great chapter written by a professor in London on Tregs. I think, and I myself have even shown after transplant, there's a surge of Tregs. It doesn't prove that they're causing the prolonged remission, but I think they contribute to it. I really do. And is there a role in infusing Tregs? Some people have developed infused Tregs, and so far the clinical studies are awash. They're not successful. Part of it is when you do non-specific Tregs, you're not targeting the appropriate antigen or antigens you need to for a disease. So you have to have kind of antigen-specific Tregs if you're going to do it, which the few trials out there really haven't done. That's much more expensive. And then the other is Tregs is a great concept, but in vivo, in the body, Tregs can flip to effector cells. They can do that spontaneously. So it gets a little more complicated, but I do think, at least in what I've done with transplant, they play a role. I do think there's a role for them in the future. We're just not there yet. I also think there's a role for CAR T cells, and CAR T cells have been reported in New
Yep.
England Journal to be effective in lupus. And the company's approached me about trying to do it in MS. I think it will have a role in MS. It will have a good effect. So yes, cellular therapy beyond HSCT is going to continue to expand in all indications, including autoimmune diseases.
I believe we're at the very beginning, probably. If only will take off significantly for the need is because the need is fantastic. So we had a question about the role of cyclophosphamide in mobilization of stem cells as you are doing it. Can you clarify the role of cytoxin in your view? Why you would use cytoxin and not do GCSF alone?
Yes. So these are good questions, but it's again, the problem with the field is hematologists treat cancer, neurologists treat MS. And so when you cross those silos, there's a lot of knowledge that has to be learned. GCSF will flare MS. That's why you don't want to use it alone.
Right.
A long time ago, I did different cytokines in animal model of MS, EAE, and GCS flared. GM CSF flared much more. TPO was the worst, flared it like crazy. Or no, FLT3 ligand, excuse me, was the worst, really flared it. TPO did not. So I guess if you can get TPO for mobilization, it probably wouldn't flare. But early days, some people used GCSF to mobilize cells in patients with MS, and they flared. Not all, but you started seeing patients flaring, so they stopped it. So you can ameliorate that and prevent it by giving the Cytoxin before. And Cytoxin, as long as you're dealing with relapsing remitting, is a very good drug for also quieting the disease. So the advantage of the Cytoxin is while you're doing the mobilization, you're giving an effective therapy to start to quiet the disease down.
Correct.
And you're also doing an in vivo purge.
Correct.
Because I don't CD34 select. And you avoid $20,000 and the headache of selection, and you're just doing autologous blood transfusion, but it's in vivo purged in the patient. So those are the reasons we do it. Now, there is a caveat there, is that the transplant dose of Cytoxin in MS 200 milligrams per kilogram. In the old days, part of my training was at Hopkins, so I knew this. In the old days, Hopkins did a dose escalation of Cytoxin, and they found when they got to 250, you got heart failure pretty reproducibly. And some people could die, but if you get them through that, they would recover. It's not a irreversible heart failure like anthracyclines would do, but it can be a catastrophe. So you have to cut the dose at 200. Well, if you mobilize with 2 grams, that's 50 milligrams per kilogram. So you're at 250 if you transplant. So what you have to do is make sure the mobilization, the day you give Cytoxin for mobilization, the day you MIT for transplant, are at least 21 days apart, and you won't hit that anywhere near that toxicity. So it's not like where you do G in cancer and you take them right away to a transplant. No, you need to make sure after the mobilization dose of Cytoxin, you're waiting 21 days. But you give it, you collect 10 days later, so you're talking about just waiting 11 more days. But it's a safety precaution that's important. And again, when you give a quick talk like I do, I can't bring out all those little issues that are important. They are in these books and in my publications.
Yeah. There's a question, why can you get when you use your data to get transplant approved as a procedure? No, so it's so the issue really is first is cost, and I'll let Dr. Burt answer this question, but he tried to explain why, and one of the main reasons is cost and the fact there's no patent. This has been this can be anyway. So do you want to add to that, Dr. Burt?
Yeah, so the whole reason I wrote both these books, including this last one, is to empower physicians and patients to take it to insurance companies. So it's there and it can't be denied. But in addition, and I talk about it in my book here, you can go to the site. I set up a website with all my talks and all my publications and everything, so you can go to it and patients can have access to it. And we have always, we're very successful in getting insurance approval, but it can take months, sometimes 10 months. I mean, it's ridiculous. And you have to just keep going back and back, appeal and appeal and appeal. And I always find we'd always attach all our publications and other relevant publications, and it never made it to the committee looking at the appeal process, never. We were always going to some black hole somewhere. So I set up a website. So when you're talking to committee, I could say to them, look, they all sitting around a table with their laptops. Go to this website. You can see our publications. You can pull them down. And that website is astemcelljourney.com. www.astemcelljourney, all one word, .com.
astemcelljourney.com.
Okay, it's all one word. And all those publications are there under the publication tab. And, you know, I've done that because I want to make sure people can get this, not just with me, but with other centers.
Right. We have our Christina coordinator is started to learn that that we have to do this, and she's the queen of appeals now. So what about okay, so Jess is asking if you would be willing to share the slides, which she wants to post it maybe on her, I don't know, website or something.
Well, I'm glad to do that. If you can condense it, send it back to me, and I'll also put it on my website. Those are the conditions.
Okay. The other thing, did you ever do a second autologous transplant on someone who's relapsed?
So specifically for MS, yes, I've done 2. Now, that's not my intention. I didn't want to. But what happened, both the patients have very aggressive MS, very horrible cases, but still a lot of inflammation on the MRI. They're still relapsing remitting. They were both really in wheelchairs. And after the transplant, they were up running, doing great. And one, you know, no drugs, doing great for 2 years and relapsed. And she was from another state. She came back and she sat in the clinic refusing any drugs till I did a transplant. So with I really felt my arm was twisted. I didn't want to do it, but I did it. And now she's 6, 7 years out and never relapsed. So, and then the other one relapsed at 5 years. We did, again, went from wheelchair to working full-time, really heavy labor work. Again, suddenly bad relapses, and now is back and beyond 5 years without ever no drugs and no recurrence, no evidence disease activity. Back to, if you look at him, he's normal with normal life. So I've done it twice, and what I've seen in those 2, now that's an N of 2, so you always have to put the caveat around that. But in that N of 2, I've seen a remission inversion. Unlike leukemias, if it comes back, you do a second transplant, the second remission is usually shorter than the first. These have a remission inversion. The second remission is much longer and ongoing in the 2 we've done. Nevertheless, I don't want to be in the position of doing that for a patient. Like I've mentioned, 23% relapse. If they relapse, I recommend some standard meds and stuff, see how they do. And only if it's acting aggressive would then consider it. In these 2, it came back very aggressive. One was getting meds, it wasn't working. The other refused meds. So we did the second transplant and they did very well.
Right.
We didn't have stored lymphocytes from the first, or hematopoietic cells with lymphocytes in it, because we're not CD34 selecting from the first transplant. So we remobilized also. Whether that would make a difference or not, I don't know.
Okay. All right. A couple quick questions. Number 1, Cy-ATG versus Cy-rituximab. Any thoughts?
Yeah. So the new trial at Scribs is running Cy-ATG, which is my standard I reported on, versus Cy-rituximab. Why do I want to do that? Well, I think short-term they're going to be equally effective. Will they be as effective long-term? I don't know. That would be the answer. The other is, then why do it? Well, Cy-rituximab is going to be cheaper and they're not going to have fevers. ATG gives fever maintenance. You have to be aware of that. The ATG will give a fever.
We are very well.
And if you think it's infection, you have to be careful for infection, broaden coverage, check for it, but 99% of the time it's not. And you have to break it with high dose steroids, otherwise your patients are going to do worse. And so I think we can avoid that. And once you get rid of infection, you can do it as an outpatient.
Right.
And hospitals are dangerous places, like I said, Legionella in our own hospital, and you can make it just cheaper and safer. And so that's why we're doing it that way. Now, on the other side, when you use rituximab by itself, or now Ocrevus, everybody uses it by themselves, you'll get patients who develop progression but no new lesions and no active disease. And that is very different than what we see after transplant. I don't understand that. You can see that if you do secondary progressive, but they're taking relapsing remitting, and they're getting, how many patients that's happening to, I don't know, but I'm getting these patients referred to me. So I'm seeing it like it's a lot. So I don't know how many it's happening to, because the drug company doesn't report long-term follow-up. But if you're on Ocrevus for like 5 years, you start getting these patients that enter secondary progressive, and they're neurologically declining with progressive MS, but there's been no new MRI activity. So there's something different about that drug. Now, if you give Rituxan with Cytoxan, you may not have that problem. I think what's different about it is that it doesn't affect the T cell compartment. You may have some chronic low-grade inflammation not picked up by MRI, inflammatory process that's destructive to these axons that are now challenged and injured because they're demyelinated, and that's probably why they're getting it. So that failure to have T cell coverage and only B cell, while it looks good very early on, can be a big problem later because they'll just gradually and slowly slip into secondary progressive. At least the ones referring to me, they've been getting rituximab and then they're secondary progressive neurologists send to me and I can't treat them anymore. And I think that's the problem, but that's not out there in the literature. Now, some neurologists I've talked to one said he's been using rituximab, and every patient that's beyond 8 years out has entered secondary progressive. And it's like something's wrong. Other neurologists say they see it sometimes, but other times, but not in the majority. So, this needs to be reported, and it's going to be up to doctors to do it. There's no interest for a drug company to do that. But if doctors can do that, it will really help the field. So it's kind of a progression without inflammation. So, but I think, again, because we're adding the Cytoxan, which is very good for T and B cells, but for T, we probably won't see that. Now, I've tried to there are some centers that have used Cytoxan, rituximab, Moscow, and Pueblo. The problem is they're not getting long-term follow-up because the patients aren't coming back to be seen. So, they say it's doing well, but, you really need a comparative trial to understand which is better.
Correct.
Yes, I'm okay with either one. They're both non-myeloablative. Cytoxan, rituximab, I think we won't have fevers. It'll be cheaper even than the Cytoxan ATG, and it probably allow us to move it to an outpatient.
And we're talking about high dose rituximab with 1,000 milligrams per meter square.
Well, you can give it one time that way, or 500 at the beginning and at the end.
Right.
Which is how I would do it.
One last quick question. What do you think about the strong reaction that we see amongst some of the neurologists and patients with MS against transplantation?
Wow. So I think the reaction is different. The reaction that I've seen with patients personally is they have secondary progressive and they want to transplant, and I won't do it. And so they're very frustrated with their disease, and that anger can come out on you as their last hope because they talk to patients gone through it and have done so well. So I realize it's never personal. It's anger for the disease, but I can't offer a therapy that doesn't help them. Nevertheless, if they're active secondary progressive, I would still do it, but non-active, I wouldn't. And those are the people that have been upset at me. It's almost like you feel like you have this thing to save their lives that you won't give to them, and that's just not true. It's not going to help them, and you have the risk of transplant, and in fact, it could even be worse afterwards. So that's why you don't do it. But that's the only place where I've seen patients really angry about it. Where I've seen some neurologists is, they don't live in our silo, so they don't see these patients come back after an autologous transplant and how well they're doing, and they can't do the procedure. Now, absolutely, there's no neurologist out there that wants harm to their patient. They want the best to their patient. But, education is a great asset. I'm all about it, but it also blinds us. It puts certain blinders. So the facts we learn today can hinder us from seeing new facts and new truths tomorrow. That's absolutely true. And I think that's definitely happens. I mean, you touch something hot, it burns, so you don't touch it again. You learn something throughout your education and you keep that reinforced, and that's how you think. And so, you have eyes wide closed, and being able to open those eyes and see something new can be a difficult process, especially from when that new thing comes from outside of the field. So I'm not a neurologist. So of course you're going to approach it with extra caution when you see that. And when you see patients saying how good it is and you see this data, then you'll say, well, it's too good to be true. But it actually is true, but it depends on the regimen. It depends on patient selection. If you don't select the right patients, you're not going to get these results. And that means, I had to teach myself MS. I had to sit at the bedside of every patient, so I know. But I can see where it's very easily for a hematologist to start treating the wrong group of patients, and they're not going to have good results. But so, and the other is with neurologists, I found generally younger neurologists are much more acceptive of this and much more excited about it and want to see it go forward. And they've gotten it, they're figuring it out. So, you know, I think being able to sit down and even present like the data I have here, look at the cost of all these drugs, where they started, where they are. Look at the cost of transplant, which is a one-time thing. So if you're on a drug, 100,000 a year for 5 years, that's $500,000. You get a one-time transplant. For 4 years, you save $400,000. You know, 75% don't relapse within 4 years with the regimen I use, the group I select. So it's tremendous cost savings to society, but it's actually not a benefit to the institution. And you know, that's another issue arising there. So I think as physicians, we need to be trained to look for the most cost-effective therapy for our patients, which means we have to be aware of what these charges and costs are, whether they have great insurance and it's still the society paying for it, or whether it's government, they're paying for it, or persons, working people who don't have insurance or have poor insurance. You know, where can they come up with this kind of money? But certainly even just the money for drugs, which is much more. But that's why I call this system, you know, financially toxic. And it's physicians, to be able to do this, cannot be employees. They have to be professionals. So if you hire a lawyer to protect you, but the lawyer works for the judge and the district attorney, he's not going to represent your interests the best. He has to be independent. A physician has to be independent to the institution that thrives off the revenue they bring in. And he has to be trained on what costs are, and trained that not only must he do the best medically and psychologically for his patient, but financially. And that part of our training has always been absent. And doctors, for some reason, have allowed their profession to slip into being employees, perhaps in return for set hours, but then you're an employee. And the system has no interest. They don't have that patient in front of them, no matter what their advertising says. They're not connected to that individual patient. They're looking at books, and they got to bounce budgets. They got to make it work. At their end, their job is to make the money work and build a new building. It's a good job, but there's nobody protecting that patient. And that is the only one that can do it is the doctor. But that means we need to be professionals, not employees. We need American Medical Association to fight for that, and they haven't. It's not going to be my fight. You know, it was hard enough work for me just to develop this new approach that I had as an idea 35 years ago. And now I'm developing a newer approach that I think will be phenomenal for aging, for which there are no real treatments but supportive care. At least it was in the animal models. So, and we'll do it as a drug development. So, you know, everybody's in a silo, but you've got to balance these silos against each other. Like one of the things I bring out in my book is doing this. One of the reasons it doesn't take off is because I'm an orphan. I'm homeless. In other words, MS is in neurology. Scleroderma is in rheumatology. I do Crohn's. That's in gastroenterology. These diseases are in other places, yet the technology to do it is in my hands once I refine it and understand the disease. And that makes you kind of homeless. It makes the system not working with you. It's like saying if it's not FDA approved, you put a scarlet letter on it. The system isn't working with you. There's a lot of things that have much more data behind them, are highly effective and much cheaper and work better, but they're not FDA approved. A lot of what we do is that way. The system has to recognize that and encourage that, and they're not. They're going the other way. So it's a systematic default. It's not an individual person default. For instance, there's no National Institute of Autoimmune Disease. There isn't. And I've spent 7 years at the NIH, and if you developed a separate institute in there, there'd be a lot of politics because there's a lot of fiefdoms and turfs. And, you know, but if you had a National Institute of Autoimmune Disease that funded autoimmune institutes at centers around the country, and in those institutes, they brought people together with interest in autoimmune disease, and you developed a board certification for autoimmune disease. And in those institutes, you had a division that handled cellular therapy for autoimmune disease, whether it was HSCT or CAR-T or Tregs. I think it would give people a home. It would give them people that they're working with, and it would cut out this almost adversarial effect and accelerate this to go forward. It's the way the institution's structured, but nobody meant it to end up in that way. It's what happened. How we got structured the way we were is originally when medicine started, you could see the skin, and at autopsy, you could see the heart or the lungs or kidney or liver. So you developed dermatologists and cardiologists, pulmonologists and nephrologists and hepatologists and so forth, because you could see those organs. And a lot of work was done to figure out how the organ works and so forth, but you couldn't see an immune cell. And then eventually when a microscope was developed and you could see it, all these diseases related to the immune cells had already been orphaned off in all these other departments and divisions. And so you got immunologists working in labs that would work on those cells, but they didn't have a clinical outlet. If you had a National Institute of Autoimmune Disease, you'd have a clinical outlet and a home and a group of people reinforcing each other. As it is now, you have neurologists who don't do it, don't see it, don't believe it, and it would lose their patient base. And you have hematologists aren't trained in these autoimmune diseases and they don't understand them. And there's a harsh and long learning curve and a devotion to doing that and giving up what you are trained in order to specialize in that. That is giving up transplanting the malignancies, which would be a hard thing to do. It's what I did. It's hard to do, but that's the key to success. It's like Federal Express. All they did is deliver packages. That's why they became successful. Submarine Sandwich, all they did is make submarine sandwiches, so they became successful. There's this attitude, we want to do everything, but then you're not absolutely an expert in one thing. Because nobody was doing this and I had the idea and I did it, I became an expert in it and I was able to see how it works, but I still see the deficits in the system that are holding it back. It's not that any one physician doesn't want the best for the patients. It's a deficit in the way our system has become organized. And that we have to start thinking about. Take the educational blinders off, and I'm all for education. I teach in a university. What I've done is based on that education. I'm sitting here before this started writing a paper, but it also blinds us. And you've got to step back and look at the forest as well as working, digging within one small area. And the problem is the people that change the system don't treat the patients. They don't do the work. So they don't know the proper way to change it, to tweak it.
All right. Thank you so much, everyone. Thank you, Dr. Burt. We really appreciate your time. It was a great talk. I think everyone enjoyed it.
All these issues are brought out in this book, and I did this to empower patients because this has to come from the bottom up.
Sounds great. Okay. Thanks, everyone. Yeah, we'll get the book. Thanks a lot.
Thank you.
Bye.
Thank you. Thank you so much. Bye-bye.